It's my pleasure to be here, and I'd like to thank the organizer for their kind invitation. I hope my time limits will allow me to cover all what I want to say in this topic. As you all know, potassium is mainly the main intracellular cation of our body, and our body pool is stable. So whatever we ingest, we have to excrete, and it's excreted 90% by the kidney and 10% by the GI. Before I explain to you how the kidney controls the potassium in our body, we have to know how the potassium is controlled on the cellular level. And as I said, the majority of the potassium is intracellular, as you can see from this slide. Only 2% are in the extracellular space, and the rest is inside the cells and mainly in the muscles. And the importance of the intracellular potassium, why it is in high concentration? Because it is needed for many things. It's needed for maintaining cell volume, for protein and enzyme synthesis and nuclear synthesis, and for the most important thing is maintaining the resting membrane potential. As you know, we have a resting membrane potential of around 50 to 80 millivolt, and it is in the negative side. And the resting membrane potential is the one which sets the stage for the muscle contraction and cardiac muscle function. That's why if we have hypokalemia or hyperkalemia, we might develop paralysis or develop fatal cardiac arrhythmias. And how the intracellular potassium is maintained in this state, it's by two mechanisms. One is active, as you can see, which is the sodium potassium ATPase. This enzyme is present in all animal cells, and this enzyme will pump for each 3 sodium that pump outside the cells. There are 2 potassium that pump inside the cells. So by this way, we are losing 1/3 positive charge. That's why inside is always negative to the outside. And the other mechanism is the movement of potassium, which moves freely through the potassium channel, as you can see from the slides. It moves freely because it moves according to the concentration gradient. But what keeps the potassium inside the cell, despite the difference in the concentration gradient between inside and outside, is the negative anion charge, which is a macromolecules that are impermeable by the cell membrane, which keep the potassium inside. So what are the factors that control this movement? First, it's hormonal factors that act either through the neutral sodium-potassium exchange, sodium-hydrogen exchange, which will increase the sodium inside the cell, that will enhance further pump by the sodium-potassium ATPase, or by increasing the activity directly of potassium ATPase, or by increasing the synthesis of the sodium-potassium ATPase. And this enzyme, the first one is the insulin, and it is estimated that if you lose half of your insulin, basal insulin, your potassium in the body will increase by about 0.5 milliequivalent just in half an hour. The catecholamines, it's a complex action because the beta agonist will help to shift potassium inside the cells and through the sodium potassium ATPase activity, or indirectly by increasing glycogen releases and increasing glucose formation and insulin release. The alpha agonist is doing the opposite, it shifts the potassium outside the cells, also through the direct action of the sodium potassium ATPase or through suppression of insulin release. Aldosterone usually acts in the kidney, but it was found that in patients who are deficient in aldosterone, if you give them aldosterone, potassium shift will happen, and this before the kidney start excreting the potassium, only if you are deficient in aldosterone. The second factors that help in this shift of insulin is our acid-base status. And in general, we say metabolic acidosis will lead to hyperkalemia, while alkalosis will lead to hypokalemia. But this is not applicable if the acid-base disturbances is due to acute respiratory. So acute respiratory has no effect. Only the metabolic acidosis and alkalosis that have the effect, and not all the metabolic acidosis. Only metabolic acidosis that due to gain of gain of mineral acid like bicarb or loss of HCl. Then you will have hyperkalemia. And I will show you the reason why now in the next slide. With metabolic alkalosis, you will have hypokalemia. Why with mineral acid, you will have hyperkalemia, while with organic acid, you will not have hyperkalemia, because with mineral acid, when HCl is gained, hydrogen will enter the cell, but chloride cannot enter the cell, as you can see from the right diagram. So to maintain neutrality inside the cell, something has to come out. So in exchange, potassium will come out, and you will develop hyperkalemia. So with hyperchloremic metabolic acidosis, you will develop hyperkalemia. But this hyperkalemia also will not persist. If your kidney and your aldosterone level is normal, it will be compensated by the kidney, and the extra potassium will come out through the kidney, and you will go back to your basal normal potassium level. In case of organic acidosis, hydrogen ion will enter the cell. Also, the negative ion in the organic acidosis, lactic acidosis or beta hydroxybutyric acid, they can enter also. The negative charge can enter, as you can see from the diagram, can enter the cell with the hydrogen. So there is no change in neutrality and no need for potassium to come out. So if you develop hyperkalemia in case of metabolic acidosis, you have to think of other causes. It's not the acidosis that causes hyperkalemia, maybe the deficiency of insulin, maybe hypoxia, but it is not the acidosis per se. Other factors is cellular depolarization. Cellular depolarization will remove the negative charge inside the cells, so all potassium will come out. That's why you develop hyperkalemia. With barium poisoning in fact is a block the potassium channel. So potassium will remain inside, it will not go by the passive movement, and that's why you will develop hypokalemia with barium poisoning. Cation accumulation in the intracellular fluid in case of lysine and arginine poisoning, because cation will neutralize the negative anion which are present in the cell, so potassium can go freely outside the cell. That's why you develop hyperkalemia in these conditions. And hypertonicity, like with mannitol and sodium bicarb, in these conditions, it said that for any increase in the osmolality of the blood by 10 milliosmol per kg, the potassium can increase in the extracellular space by around 0.4 to 0.8 milliequivalent per liter. With cell necrosis, of course, you will develop hyperkalemia because potassium will come out of the cell, and the hypokalemic periodic paralysis, where there is shift from inside to outside. It's sometimes genetic, sometimes acquired. Now I'll talk about how the kidney handle potassium. The kidney usually adjusts overall potassium in our body by either decreasing or increasing the rate of excretion of potassium. And the rate of excretion of potassium mainly depends on concentration of potassium in the urine and the urine flow rate. So there are two factors that work in the potassium excretion. And potassium concentration in the tubules is mainly worked in the cortical collecting duct, where the secretion of potassium will happen. This is the main site that controls it. This is just a diagram showing you how the kidney filter potassium 100% by the glomerulus, and then it is reabsorbed, 70% reabsorbed in the proximal convoluted tubule, and then 25% in the ascending loop only. Only 5% will reach the distal tubule. And this it might be reabsorbed on the condition by sodium chloride in the distal tubule, but it will be secreted, only secreted in the cortical part of the common collecting duct. The secretion of potassium will occur there based on what? Based on many factors. Among these factors is how the sodium is absorbed in that part of the collecting duct. If the sodium is absorbed in electrogenic matter, or it is electroneutral. If it is electrogenic, that means we absorb sodium through the sodium channel more than we absorb chloride. So in this case, then the lumen will become negative. The more the negative the lumen, the more potassium will be secreted in the lumen of the collecting duct. So it depends. And this sodium absorption is dependent on, through the sodium channel, is dependent on the aldosterone, your aldosterone level. Okay? But if it is absorbed in electroneutral way, then the sodium and chloride will be absorbed there will be no change in the charge in the tubule, so there will be no potassium excretion. The other factor is the rate of the flow of the urine to the distal part of the tubule. The higher the rate of the flow, if the patient is volume overloaded, then more sodium chloride will be absorbed in the distal tubule, and this will enhance more potassium to be secreted in the tubule. So the flow rate will affect the potassium secretion, the concentration, as we just said, and the presence of negative non-reabsorbable anion in this part also will enhance, like presence of bicarb, presence of sulfate, phosphate in that region, also will enhance potassium secretion and your intake of potassium. If you take too much potassium, then there will be more secretion of potassium in the urine. If you take less secretion and maybe reabsorption of potassium. And this is just the cellular model to show you the cells that really worked in this part of the collecting duct, which is the principal cells that lead to the secretion of potassium, and the intercalated cell, where it is the absorption fact of potassium happen in exchange of hydrogen, and where how the kidney help in adjusting the acid-base balance. Now we'll go to the channel approach to hypokalemia. If the sodium channel, which I talked to you in the previous, I told you if the sodium channel is too big, then you will have what? You'll have more negative charge and you will have hypokalemia, right? What caused sodium channel to be too open? Presence of hyperaldosteronism. In case of Liddle syndrome, Liddle syndrome is what? There is a genetic defect in the sodium channel. So there will be too much absorption of sodium, that's why they present with hypertension and hypokalemia. And it's important to know that because these patients will not respond because it is the defect is in the sodium channel, so they will not respond to spironolactone like the patient with hyperaldosteronism. They only respond to amiloride. So the treatment will be amiloride rather than spironolactone to treat this patient hypertension. Amphotericin B is acting by different mechanisms. It inserts a positive cation inside the cell that absorbs sodium. So it will not respond, the treatment will not respond to amiloride, it will not respond to spironolactone. The only treatment is to stop the drug, which causes the sodium channel to be wide. The other cause of hypokalemia is the chloride channel is too close. Where you find chloride channels too close, you find it in Bartter syndrome, in Gittelman syndrome, in magnesium depletion, and if there is more bicarbonaturia in the urine. Bartter syndrome and Gittelman syndrome, these are genetic disorders. The difference is Bartter syndrome is the defect is in the ascending loop of Henle. So they act as if, these patients, they act as if they have received furosemide as a diuretic. So they will have hypokalemia, metabolic alkalosis, and they will be extracellular volume depleted. They will not be hypertensive. While in Gittelman syndrome, the defect is in the distal convoluted tubule, where the sodium chloride is absorbed there, and where thiazide is working when we give thiazide to patients. So they behave as if they were on thiazide diuretic. So how you will differentiate if a Gittelman can happen at any age, from 1 to 70 years of age, but Bartter syndrome usually in the younger age group. But you can differentiate between both by the amount of calcium in the urine. In Gittelman syndrome, there will be hypocalcemia, hypocalciuria. There is no calcium, and calcium level in the urine is low. While with Bartter syndrome, the calcium will be normal or even high. The same effect of the thiazide diuretic, that's why. So easy to remember in this way. What are the clinical features of a patient with hypokalemia and sodium channel too open? They will have extracellular volume expansion, they will be hypertensive, they will have low renin, and they are able to concentrate and pass salt-free urine with extracellular volume depletion. What are the clinical features of a patient with hypokalemia and chloride channel, which is too close? They will have extra volume contraction, they have normal blood pressure, high renal level, and the urine sodium and chloride will remain high even if they have extracellular volume depletion. This is the diagnostic approach, which I will not go through it. The treatment, of course, it depends on the urgency of the situation. You treat it fast, just to get the patient out of emergency. And then the rest, you have to give the rest of the amount the patient needs through a longer period, slowly. And the degree of the deficit is hardly you can detect from the level of potassium. But roughly, they said if potassium drops from 4 to 3 milliequivalent, that means you have the deficit in your body is around 100 to 400 millimole. And if potassium is 2, your deficit is around 600 millimole. And the way to solve this problem is to give the safest route is to give the potassium supplement orally. And if it's needed through IV, then, and if you give it through peripheral vein, you should not exceed 20 to 40 milliequivalent per liter, because otherwise you will cause vasospasm and pain to the patient if you give in a higher dosage. My time is running fast, so I don't know if I'll be able to cover everything. Let's say the channel approach to hyperkalemia is the opposite. The sodium channel will be closed, and in which condition you have sodium channel closed in aldosterone deficiency, in drug like amiloride and trimethoprim, and or chloride channel 2 open in Gordon syndrome and cyclosporine. Gordon syndrome is the mirror image to Gitelman syndrome. So they will have hypertension and hyperkalemia, and they respond to the treatment. What treatment do you think they will respond to? Thiazide. So the clinical feature of patient with hyperkalemia and sodium channel which is too close, they will have extracellular volume contraction, they have low blood pressure, they have high renal level, and they will have salt losing in the urine despite extracellular volume depletion. What about the clinical feature of a patient with hyperkalemia and chloride channel which is too open? They have extracellular volume expansion, hypertension, low renal level, and the urine sodium and chloride will be low if the patient has extracellular volume contraction. And this is the diagnostic approach. Treatment, you have to reduce membrane excitability. As you all know, you give calcium gluconate or glucuride or chloride, but a preferable gluconate, because chloride, if it extravasate, it will cause necrosis. Use shift of potassium from outside to inside through sodium bicarb, insulin with the glucose, or beta-adrenergic agonist, or remove potassium by giving cation exchange resin. All of you know about Kexilate. The newly available is Batiromir, which is approved in 2005, and it is more effective than Kexilate, and its effect will appear within 7 hours, and you can use it even in patients with CKD. And the other one is zirconium cyclosilicate, which also its action is within 2 hours, but it can cause edema and hyperkalemia, so you have to be very careful. You can remove it by hemodialysis or eliminate potassium intake. And the diagnostic tests which are available is 24-hour excretion of potassium, or potassium creatine ratio, or transtubular potassium gradient. And just why 24-hour potassium excretion is the best, because of the diurnal variation. And the expected value is hypokalemia, it should be below 15, and hyperkalemia more than 200. The easiest is to do potassium creatine ratio in the urine, and the expected value, if it is hypokalemia, it should be below 1, and if hyperkalemia, below 20. If it is beyond this expected value, then means the cause is the kidney. Then you have to find out, is it due to concentration problem or is due to flow problem? The best way to define is by measuring the transtubular potassium gradient. And this is how to measure the transtubular potassium gradient. I don't think my time will allow me to show you all this. Because the transtubular potassium gradient will tell you exactly the potassium in the cortical collecting duct. Because it is in the urine, it might be different. It might be higher or lower depending how much water we absorb through the medulla and the kidney. And this slide just to show you. In both conditions here, that transtubular potassium concentration gradient is 3.3, while if you measure it in the urine, in the first diagram, it is 10 millimole, and in the other one, it is 40 millimole. And that's because of the absorption of water in the second one than the first one. And this is the expected value, and if it is below that, you can give the patient alpha-fetocortisone and see the effect after 2 hours. If it improves, then the problem is in the aldosterone status. I think I'll stop here because my time is over. I just want to
Dear doctor, your time is up.
I just wanted to show that I'd like you to attend our meeting in Dubai, which will be in November. It is about International Society of Organ Recruitment, between 14 to 16 of November 2019 this year. So you are all welcome to attend. Thank you for listening.